Hi everyone, welcome to the LX SLT MIGS Symposium Roundtable. I'm very happy to have a group of surgeons with me today to talk about SLT and MIGS. My name is Ike Ahmed from the University of Toronto, and with me I have Mahmoud Kiami from Oklahoma City, Oklahoma, Mark Gallardo from El Paso, Texas, David Richardson from Los Angeles, California, Nate Radcliffe, New York, New York, and of course Paul Singh from Racine, Wisconsin. Today we're talking about different paradigms in glaucoma therapy, focusing a bit on SLT and MIGS. Now guys, I want to keep it pretty open to start off, just talking about your current treatment paradigm for open-angle glaucoma. Tell me your thoughts. And don't all jump in at once, please.
Well, I think it depends on your target pressure, of course. But for me, I'm trying to maintain, really patient quality of life is always key for me. So how can I get those pressures down, maintain them long term, but maintain a high quality of life? So I'm a big fan of trying to minimize patients' reliance on drops because of all the compliance issues that we face. So for me, I tend to try to push towards laser trabeculoplasty like SLT as a first line if possible, and if I need to, then produce drops if I need to. But I'm trying to minimize the impact of compliance on a long-term disease like glaucoma.
Okay.
I also use cataract surgery as an opportunity to actually treat glaucoma. Of course, in the past, if somebody had glaucoma, and even if they were controlled, I would never fathom coupling a glaucoma procedure with a cataract. But now with MIGS, because they're astigmatically neutral, their safety profiles is fantastic, I really try to use that opportunity to reduce the patient's medication burden. So if I'm going into cataract surgery, if somebody's on a medication, I automatically couple that procedure with one MIGS procedure.
So we can kind of draw buckets in glaucoma therapy. We have the medication bucket, we have interventional therapies like laser trabeculoplasty and MIGS, and then we have more traditional surgery. So tell me a bit about how you incorporate SLT and MIGS in conjunction and how you use it in practice.
So my treatment paradigm, Ike, is I usually will go to SLT primary and then MIGS, ABICI tract after that, and perhaps try SLT again and then maybe some other MIGS, and then it's pushing back the filtering surgeries and the tube surgeries further on. And so medication has actually fallen to maybe an adjunct in between those treatment paradigms. So I know it's a little pushing the buttons there, but I think that's the way we're heading.
I agree with that. I think that, at least here in the U.S., there's always been an issue with going straight to procedures in terms of, is that something that is acceptable medical legally? But the safety profile of SLT is so great. I would argue that it's actually a safer first option than many of the medications. I mean, we talk about, for example, the beta blockers as being potentially an issue. I don't think people really realize how much a beta blocker really can impact somebody, not just the older patients, but I had a younger patient who was athletic. He ended up in the emergency room. He was laughing about it to me because I had warned him it was possible. So, oh yeah, you told me it would be the case. But medications, not only is there an issue with adherence, cost, which even now you can't assume the generics are going to be cost effective, but in terms of just risk, I've never had anybody in the emergency room after SLT, never.
It's also toxicity, you're right, and also toxicity of medications and diverting fluid away from the natural outflow. The majority of our drugs are kind of bypassing the natural outflow system until recently, and I think having the ability to help maintain the flow through the TM, as well as and hopefully maintain the flow through the trabecular meshwork, as well as the canal and distal channels, helps for me personally think about MIGS later on in the future, because I want to maximize as early as possible the flow through the natural outflow system. So when I have to do a MIGS device, then I feel personally that I'm priming that area for the MIGS device. So I think earlier intervention like a trabeculoplasty to maintain it, help decrease compliance, but also minimize toxicity and help the flow is, I think, really important. So
it sounds like most of you here are using SLT earlier in the treatment paradigm. It sounds like patients are receiving that option quite well. Other than you thinking about it as a primary therapeutic response, how do you feel about using SLT perhaps as an indicator of success or response to MIGS? Any thoughts on this?
Well,
You should ask.
It's funny you should ask
Paul,
that
do you want to
question.
take a stab at this one randomly?
So I've been a big proponent. Of course, we actually, we have found in our data sets, again, this is something that we're working on being published right now, but we did a retrospective analysis of our iStent cases, actually. Had at least 1 year follow-up. And what we found was that the patients who, iStent overall did very well, but we found in a subset of patients who had as previous SLT, in the patients who did not have a good response historically to SLT, ended up not doing quite as well within the SLT response in the group versus the ones who historically had a good response to SLT ended up doing better with the iStent. So that was my first inkling that, well, think about it. Where is the SLT working? At the TM, the pigmented epithelial cell, right? So the idea is if it works well, you're helping to realize that the flow is probably good in the canal and distal channels. If it doesn't work well, then there might be some downstream resistance. So that kind of helps me decide, okay, well, if it's not working with the SLT, focus on posterior to the TM potentially. So that's what I've been thinking about recently, and hopefully it's going to pan out either way. We'll find out.
Any other thoughts on anyone have experience on this?
Yeah, so I'm not as smart as Paul, so whether it works or it doesn't, I still will do ABIC eye tract afterwards because I think it's a little bit more powerful and it comprehensively treats everything. So perhaps you weren't able to open up TM well with SLT, but this, with viscodilating so much of the canal, I think it opens up TM well. So to me, SLT is a good indicator if it will work. If maybe you want to use iTrack ABIC afterwards, but also if it doesn't work, that doesn't keep me from doing ABIC iTrack.
Yeah, no, I agree with you.
Yeah.
I mean, I think that's one of the most important points. Is I probably wouldn't do a TM only device, especially if they had a failure.
Absolutely, yeah.
So that's where I think the
Yeah.
ABIC can really help out in those cases.
Important data.
Absolutely.
We're sort of moving towards standalone, MIGS types procedures, and SLT is sort of the grandfather of standalone interventional procedures. And a patient who did well with that intervention is sort of psychologically primed to maybe consider, hey, I trusted Dr. Radcliffe. He told me there would be a laser that I would recover very nicely from and that could work. It worked. That was 3-4 years ago. Now things have changed with my glaucoma. He's recommending, ABIC, I'm sort of buying into this paradigm as a patient, and then as we gain those experiences and confidence with things like SLT, we'll feel more confident offering these safer standalone MIGS procedures and changing the overall paradigm to what Ike has called interventional glaucoma.